Acute promyelocytic leukemia represents around 20 to 25% of the AMLs in Latin America, based on the literature on hospital registries. Is still a disease that is a challenge for us, especially because of early mortality. We about 10 years ago, we used to lose about 1/4 to 1/3 of our patients in the first 14 days. Due to the initiative of the International Consortium on Acute Leukemia, which is an initiative sponsored by the American Society of Hematology and congregates several institutions in Brazil, Peru, Chile, Mexico, Paraguay, we have managed to reduce this to something around 11 to 12%. So it's a significant improvement, but it's still higher than it's reported, for example, by the PITEMA group in Spain, or from the results with arsenic trioxide and ATRA treatment, the so-called chemo-free treatment that was published by Dr. Francesco Lococo. So there is still a challenge, and still we are trying to make the doctors very aware of this disease and to initiate as soon as possible with ATRA treatment and transfusion support. Apart from the early mortality that, as I said, we are still dealing with the problem, another problem for us is when the patient relapses, because the standard of care today should be considered arsenic trioxide. Arsenic trioxide combined with ATRA, or arsenic trioxide combined with chemo, but the fact is that's an essential drug that unfortunately is not available for the majority of our patients due to costs, in fact. So when you have a relapsed patient, which represents something around 10 to 15% of our patients that actually pass the early mortality phase, then we have a big problem. Sometimes the patients, the family, they can afford the drug, which is a minority of the cases, but in many cases we have to give AML-based chemotherapy, which is far more toxic, and it's associated with mortality and morbidity that nowadays I don't think would be acceptable anymore. So in these cases, we usually move from the chemotherapy and induction, and then we do an autologous transplant, which in the end comes to the problem is really cheaper what we are doing. So I think we have to concentrate our efforts to get the drug, a cheaper arsenic trioxide to our region, and to allow at least in second line. I think it's not acceptable not having arsenic trioxide in second line. And of course, if we want to provide the same chances of cure for patients in Latin America and other countries with lower income, we should also consider the drug also for first-line therapy.